met him. I was introduced to him by Dean Linda Rosenstock of UCLA, and he's ever the quiet leader in the background. He never likes any spotlight, but he quietly put in a request for a grant from the NIH to implement these promising best practices, which include the topics that Arnie Milstein was just talking about. So outpatient intensive care, medication protocols, clinical pharmacists on the care team, and at the apex, of course, activating the patient. So you all have this triangle in your packets. So in the packet, you have the project brief that talks about the genesis of the project, who our funders are, what our interventions are.
There are too many people up there. I'll wait until San Diego's done. How about that?
Well, just grab a chair and come close. So with the NIH grant that Bob Kaplan obtained, I didn't even know he wrote the grant. So he comes on the project, and being the quiet guy that he is, he writes a grant with Alan Fremont, who is here at the table with us. They don't even tell me they've written a grant because the odds of receiving a grant from the federal government, right, are so low. But much to my surprise, Bob calls me on the last day of the federal fiscal year and says, by the way, we just got a big grant for the Right Care Initiative to take these interventions and implement them in one community. We had been talking for quite some time about doing something in San Diego because we knew that we had a couple of big negative outliers in San Diego that I mentioned this morning, where we had this anomaly where two highly respected delivery systems were performing well below their statewide sister institutions. So, as we all know, Kaiser has outstanding performance statistics in blood pressure and lipid control in particular, but not in San Diego. At the time we looked at the data, we're like, what is going on in San Diego? It's just not looking good. And the actual data is in your packets. It's in the project brief that says university best practices, and it describes in great detail who's involved and where the funding comes from, and actually shows you the data by medical group. So both Kaiser and UC San Diego were performing less well than their sister institutions across the state. So that drew us to San Diego, in addition to a couple of really important other factors, and I won't go into great detail, but the year before we had given the leadership award at the Right Care Initiative to Jerry Penso, because his group had not only gotten the Platinum Award for Sharp Reed-Steele Medical Group for all of the, meeting all the national 90th percentile goals of the Right Care Initiative across diabetes and heart disease, but he had also been very much wind under our wings, saying, just because industry doesn't want you to hold them accountable for their data doesn't mean you should stand down. Keep going. So we knew that we had a really strong leader, and frankly, to make anything happen, you have to have strong leaders. So we found two amazing leaders in San Diego. The first one we already had because he was already part of our, what I call the Right Care family, which is our big enthusiasts who make all this work, and there are an awful lot of them building in this room. But it took quite a long time to find the right cardiologist to help co-lead our university best practices. Now, Jerry Penso, our first co-leader of university best practices, with whom Bob Kaplan and I strategized, along with Warren Barnes, about creating something called the university best practices. But it took a while to find out who's the right cardiologist to help co-lead it. It took me several months to get an appointment with Dr. DeMaria because he was doing international travel so much, and I needed to fly down to San Diego to meet him. But as soon as we met, it was clear that he was really passionate about this topic, and he volunteered to start a technical advisory group to help us get something started in San Diego. So with that, I'd like to say, you saw the results this morning, very impressive impact in San Diego. And now I'd like Tony, if you would, just to come join me at the podium and talk a little bit about, what are you doing now in San Diego? We started that in February 2011 after a year of meeting individually with all the medical groups in San Diego, having 2 summits down there like this during 2010. And then Tony, hit the gavel on the first Monday in February 2011, and he's been doing it every month ever since. Now, I'm so grateful that Tony has kept it going, that Liz has kept it going after I broke my ankle and could no longer go down there. Happy to be back on my feet. Thrilled that Kitty is now the executive director, keeping it going, getting new funding, and they're completely independent, and they're going to show the nation a new way of dealing with population health. And as we saw this morning, we've seen a 14% decline in MIs, hospitalizations in San Diego relative to the state. So it's really impressive. Through a lot of it is very proactively using that medication protocol. So with that, I'd just like to say this is a huge team effort. So all the people involved with our university best practices can't fit at this table. Right now we have predominantly San Diego with us. And with that, I'm going to say, if it weren't for the Health Services Advisory Group helping us to provide continuing medical education for these sessions, and helping us to bring in really great top performers from around the country, we wouldn't be here. So there's just a huge team effort to make this happen. But Tony DeMaria, being a world-renowned cardiologist, if you don't know him, he's the immediate past editor-in-chief of the Journal of the American College of Cardiology. He's trained a whole lot of the cardiologists in this state. He helped to build the UC San Diego Cardiology Center, and he is a beloved member of the San Diego community, and he has earned sainthood in my eyes. So with that, it's going to be hard to have the energy to explain in 20 minutes all the good work that you've been doing.
Yeah. Would it be okay if you said all those things again and I recorded them for my mother?
They're being recorded.
Okay. I guess as I've said many times, if I send it to my mother, she'll be thrilled. My father will be greatly amused. In any event, this was really Jerry Penso's idea. Obviously, we all shared the enormous passion to reduce heart attacks and strokes. They occur in people who are often in the midst of the most productive years of their lives. They affect entire families. It's husbands and wives and parents and children. So we all had a great passion to do that. But Jerry was the one who said, we can mobilize the physician community, he believed, if he got us together and people who were doing very, very well, as Jerry was, said, here's what we do. Here's what we do. And the rest of us, being concerned, would say, God, that sounds like a good idea. We'll go back and implement that in our system. So that's the way we started out. Once a month, Hattie and Liz would convene this group. Jerry and I would oversee it. And we talk about some aspect of medical care. It ranged from how to incentivize patients to disparities with Dr. Rodney Hood or whatnot. And then we would break up into discussion groups and talk about how we could see ourselves introducing that into our own practices. Now, over the months and years that we've been doing this, the discussions have shrunk a little bit, and the presentations have gotten a little bit longer, and we've formed what we call a data group. This was also a first. I think if there's, among the things we feel very good about is, believe it or not, every single one of the participating, maybe not every entity, but pretty much every entity that was participating in San Diego agreed that they would send their data on blood pressure control, on lipid control, on hemoglobin A1C, and it would go into a repository that we could use to track ourselves. And we'd look at the data, Alan will tell you about that in a moment, without identification of the centers they were coming from. Of course, you knew what your own data were. And, for highly competitive healthcare systems to do that was really amazing. And so this data group we started out just, was it possible? Could we get the data? And now we're working hard to try to do it in a uniform fashion. And this is really, we see as a major step toward an accountable healthcare community where everybody's working together. And having said that, we've got some of the most active people in our program that are here, so I'm not going to say any more. I think what I'd like to do is to start with some of the physician participants, move on to a little bit about our data, and finish up with our fearless leader who really runs the show. So Parag, let me start with you. Why don't you give us your perspective of why you got involved, what you hope to get for it, how you think it's gone, and where you'd like to see it go.
I thought I could do was I could talk of the CMMI grant, and you want to start?
Oh, that's what you want to do?
Yeah.
Okay.
But I think,
So
the reason I got into this
We'll
was
just
because
say-
I was the next Jerry Penso in San Diego. So and I was part of the Sacramento initiative. I think we started the Sacramento with Harry before I moved to San Diego.
He was our first co-chair. He's just very humble.
Right. So when I moved to San Diego and I took over Jerry's job, all the responsibilities came with that. So, but I think we it has been a very good learning. And what I'll do is I'll speak about the CMMI grant which we are applying, and I think I would pass on to Kitty.
Go on to Ray.
Yeah, Ray and then Kitty or something. Yeah.
Good afternoon, everyone. So I'm Ray Bogany, and I represent Kaiser Permanente San Diego. So I joined the group, and I remember the days. Why I joined, well, whether you say Hattie Hanley or whether you say the Department of Managed Healthcare, you need to go to the table, right? It's kind of that voluntold thing. So I was voluntold by my medical director and CAO, the Chief Administrative Officer in San Diego, to attend. So some of you may have been in the position where the bosses are up here, and then the next level's here, and then you're here, and there's really no one else to go. And so I went, and the group I do want to share, it was Jerry Penso and Dan Dworsky. Let's see, Jim Duddle might have been there, and we met on the UCSD campus. And I remember the season, it was a little rainy and cool, and we're trying to skedaddle from clinic and from our work. And we would get to a table, a room, not quite as big as this, with the classic conference room oval table, and the 4 or 5 of us take up less than half of it. And we literally sat in the room, and this is what you heard. for a good hour or two. And we would lean forward, because, right, you're supposed to lean forward, and we'd sit back, and we would take some notes, and we would check our email or text somebody, and that is how it actually went on for months. So I do join Hattie in saying we're really minimizing how huge this effort has been in San Diego to bring together all of the health plans at a table once a month, and now how it's expanded to all of those representatives that Tony showed us earlier, to actually talking and communicating. Because literally, we sat there like duct tape was on our mouths and sitting on our hands. So why we were all there is the same for all of us. We wanted to improve the health of our San Diego County community. So the challenge was communicating and sharing the data, and Alan will tell you how that got started in a couple of minutes. And so we finally moved forward. And the gentleman, he came and he was from the Beacon, research, to get all of the data together. And as you all know, when you never know where your data's gonna go, right? And so to have data and have it say Kaiser Permanente or UCSD or the VA, we said, oh, we don't know about that, we don't know about that. However, when we made it unblinded, and then we kind of took away I guess that's a stigmatism, right? We kind of took it away saying, well, let's not talk about whose data, let's talk about how to improve everyone, right? Let's talk about the patient. Put the patient at the center, and let's talk about how to improve this patient, this San Diego County resident's blood pressure, diabetes, and cholesterol. That's when we said, oh, okay, we could talk about the patient. And that's really how the conversation moved forward to these amazing speakers coming in during the lunchtime, where we're overlooking the finest city in the world, as we say, overlooking the beach there in San Diego, while the surfers are out and we're sitting inside. We have yet to hold a meeting outside, but nonetheless, that's what we would do. And we began to know each other by first name. We began to send emails. How are you improving mammograms? How are you improving this? So even expanding outside of the cardiovascular disease risks and conditions. And that's how we made the improvement. And we would get the community involved. And the bottom line is we're all there to improve the health of our community. And so one of the things possibly unique about us, but likely not with you in the room, we want all Californians to be healthy. So that's, again, where Hattie and where Liz come in, and the other sponsors, right? Which with Mary, where we want all Californians, and then we expand out of California to the United States. So that, in my opinion, is how we are all coming together, trying to close disparity gaps that Michael Cantor talked about earlier, trying to talk about which tests are the best tests. So that's how and why we're really all involved in really talking to each other. And it's actually more cordial now, and there's a lot more noise in the room.
Thanks. Why don't we just go right down the line? Alan, give us your perspective.
So, one, having a beautiful beach in the background is a key to success here. That helped a lot in getting people to the table. And Ray was talking about we never meet outside, but one of the inside jokes is when we look at sort of where we started in late 2011 and sort of how things have progressed and evolved over time. Often we have a slide of a bunch of us huddled around tents, and then a couple years later we finally have a little van again, and now we've got a motorhome, and we're really moving forward and some funding. But one of the things when people hear data group, it has a mystical quality, and we actually initially would meet in a corner of the big room, and then eventually we got promoted and we got our own room. And it was fascinating because we'd meet before the University of Best Practices, and data group conjured all kinds of mystical stuff, the people who weren't part of it. But I want to let you know we did real work there. But what people I don't think fully appreciated, and you're hearing Ray and others allude to it, was, quite honestly, the sophisticated data analysis, getting the data. There were some hurdles in getting the different groups to compete, to share it. But really, a lot of the early stuff and what laid the foundation for what we've been able to accomplish since is really getting people around the table, around some common goals. And we had this sort of mixed bag of this was a place where first and foremost, we're all coming together because we want to do something that's impactful beyond what's going on in the organizations. We want to actually have an impact at the population level. At the same time, there was real interest and enthusiasm in learning from, and being able to sort of share and learn, how some of the other places are doing, accomplishing some of their stuff and where are the challenges and so forth. Anyways, so the data collection, we started at, this is Jerry Penso's rule of start easy, low-hanging fruit. And really, we for a long time worked with aggregated data, at least what we were collecting and pooling together. But what happened pretty quickly as we started to meet in that group is people from the different groups, the systems were very generous and would start to show much more granular data. They'd start to show, this is specifically what we're doing within our organization. Here's how we're accomplishing stuff. We did a little bit of facilitation, but really within a short time, not only did you have trust, but you got to really leverage the collective talents and the different perspectives of these folks at the table. I think one of the other things that helped is this is a very mixed group. We have commercial, provider groups that were doing commercial care, some that were doing community clinics, some Medicare and so forth. In any case, we're now moving on to, we've got some funding. It's really now starting to be more institutionalized, and we're moving on to collecting much more granular data in the coming year, and really starting to look at some of the sorts of, look at subgroup differences and in different areas, and see what's working. We're starting to look at more of the community impacts, but again, it's sort of the informal building trust that was key.
It's been said many times, physicians are the most competitive people in the world. And the minute you start showing them their data, if their data aren't as good as someone else's, they get very energized to make things better. And I think that the fact that we've been able to gather that data and show that data made a huge difference. It became clear early in the game that we needed someone whose day job was to make this program successful. And with Hattie and Liz gravitating back to Northern California, their home base, we were enormously lucky to get an extraordinarily talented individual who really has been the force to bring us together, keep us together, and get us moving even in the future. Kitty Bailey is our executive director. So Kitty, why don't you give us your perspective? And
Sure.
maybe introduce the grants that Parag is going to talk about.
When did you start in San Diego? It's all a big blur to me.
I started in June 2013, and we were very lucky. We have the partnership, and I think this is an important partnership to mention. We have a partnership with our County Department of Health and Human Services, and one of the things I think that I spend a lot of time doing with help from Alan is bridging the gap between public health and clinical medicine and services and healthcare systems, because that is a part of the solution as well. Public health has a big part to play in this, and they want to be partners with healthcare systems in that, and it's a challenge for them, and I think it's a lot of opportunity for both sides to learn from each other and gain quite a bit. So I'll mention that is the funding, actually, that was used to support the hiring of this first executive director position. County of San Diego had a community transformation grant, which was out of the Centers for Disease Control. Those grants no longer exist, but the CDC continues to have what they call a prevention portfolio, and most county public health departments access those funds in a variety of ways, and it's a great way to start to look at funding, sustainable funding for the University of Best Practices and the projects that come out of that. So I was hired and brought on at that time. I'm housed at the University of California, San Diego, because I needed an employer at that time. And after some wrestling back and forth between our choices, probably narrowed down to the county and UCSD, it was decided that UCSD would be the most neutral entity in San Diego to house our initiative. And so I've been housed there ever since. What my priority was in starting, one, very clearly was to submit a CMMI HICIA Round 2 application. So that was right away what we did. But then really to ask our leaders to attend another meeting, which is always a tough thing to do, but we decided to form what we call an executive committee, which is a fairly small group. We only have about 15 folks on it and almost acts as a membership organization. So we have a representative from Sharp Steely, we have a representative from Kaiser, we have a representative from all the major medical groups. And so this is a meeting that they attend in addition to the University of Best Practices. And we really ask them to act as overseers of our entire project, almost like a board of directors of a nonprofit would act. And we've created some governance documents to help us do that. Once having that committee seated, we decided to go ahead and do some strategic planning because we have a big, hairy, audacious goal to eliminate heart attacks and strokes, and we needed a roadmap to get there. And so we spent an entire day. So I asked them to come to another meeting, an 8-hour meeting at the country club, and got them to define a roadmap for their staff, me at that time, to help think about how do we move this project forward. We chose 3 activation areas: healthcare team activation, community activation, and then the healthcare system activation. And we've been very, very lucky over the past several years to receive funding in each of those areas. Parag's going to talk a little bit about our healthcare team activation, which is funded under CMMI. And, okay, I want to take 1 minute to mention to this room our Centers for Disease Control Racial and Ethnic Approaches to Community Health Project, which is a project we're doing in southeastern San Diego where we're partnering with faith-based organizations on a magical thing called community clinical linkages. And I think it's going to be the key. We know that community, that's where heart attacks and strokes are happening, the vulnerable African-American community in southeastern San Diego. And by partnering with faith-based organizations and the leadership of those pastors, we have access like we've never had before to congregations and populations who don't trust the healthcare system and aren't taking their medications, and their hypertension isn't controlled today. And a lot of the things we talk about in this room, we all know what we need to do, but until we get out and have those relationships and conversations with those folks, the real change won't happen. We won't get to elimination until we reach that population.
So just before Parag speaks, I might point out that we were sustained in our earliest times by a philanthropic grant. Jack and Judy White were kind enough to give us a very generous philanthropic gift of $500,000 that kept us going, keeps us going. I mean, we didn't spend it all, but sustainability is obviously very important. Parag.
Right, thank you. So just to build on the sustainability, I think what happened was that if we hadn't, applied for grants, we wouldn't have had any mission. So we applied for the CMMI grant, and thanks to Region 9 CMS, that they motivated us to apply for this grant. Right. And we won the Health Innovation Grant from CMMI Round 2. As part of the grant, I'll be just brief, our goal is to see if we can enroll 4,000 members and reduce the burden of heart disease and stroke in the San Diego community. So we have now 9 healthcare systems participating in this grant, from Scripps, UCSD, Arch, community clinics. And also as part of the grant, we also have project manager Christy, who is in the back there, who helps us out with a lot of the projects. In this, we are looking into 4 arms. One is healthcare team activation. Basically, it's around health coaches. How can health coaches help with a lifestyle intervention? That's the first step of any of these projects we have heard about. The second is around technology part. So we are looking at how we can deploy certain wireless blood pressure cuffs or different kind of technology to really drive medication adherence or drive compliance or control of blood pressure. The third is we also have a medication protocol, which, I think we spent a lot of time on medication protocol. Even though the former members of JNC 8 came out later on, we all, as a collaborative had already formed a protocol on what would be the first line treatment options. The fourth part is, data is a big part of how we are going to drive some change. And the last is the payment. Our end goal, CMMI has requested that as a part of this grant, that if we succeed, how can we really drive a payment change in the community towards population health and engaging all the healthcare systems? So rather than paying piecemeal fee-for-service model, how can we change that? And I know there are a lot of models on ACO, et cetera, but that's a big challenge we have to address. So our goal is 80% control of medication, 80% blood pressure control, and then we can show those results. We're happy to say that in the last, every project takes time to start, but all the systems are on board, and Christy's doing a great job, but I think we have almost, as of in 7 months, we have 1,000 members already enrolled in the program, and we hope to continue the momentum.
Okay, so that's San Diego. Thank you very much for your attention.
So we started San Diego in February 2011, officially with University Best Practices. We started in Sacramento, who we're going to hear from now. If you would go ahead to the head table. Neil Mohammed, could you join us, please? We started in Sacramento in June 2012 when Parag Agnehootri was still with us in Sacramento before he switched jobs. And we started Los Angeles in April of 2013. So it's been a rather frenetic time of getting these groups up and going. And it's all about the leadership. So Mary's got some slides that are going to help us think about. We're working on getting up a audience response question for you.
Okay, let's see if you're still awake. Here's a question for you. Which of the following evidence-based practices are shared in the University of Best Practices? Effective use of medication protocols and treatment algorithms, team-based care that incorporates clinical pharmacists for medication therapy management, evidence-based patient activation and education, home blood pressure monitoring, or all of the above? Okay, let's see. It's a simple, easy question, huh? All of you got the right answer. Good. Now, I'll turn this over to, is it Dr. Ertl? Yeah.
So are Dr. Ertl's slides ready?
I'll get up to the podium, that'll be easier. You have-
Yes, yeah. Well, I don't have the clicker, but. So it's really exciting, the sort of cross-fertilization that happens between San Diego, Sacramento, Los Angeles. That's where it's starting to get really, really fun. And Dr. Ertl's work is very impressive in his leadership of our